So my talk's entitled Maintenance Therapy, State of the Art or State of Confusion, where I was specifically asked whether we should switch, continue, or delay, and I guess the answer again is yes. Here are my disclosures. As Marcia pointed out yesterday, I am guilty of pharmaceutical promiscuity, and this is proof. Please note that my Speakers Bureau involvement ceased well over 2 years ago. So again, I think we have to really look at the terminology. Is this maintenance? Is it consolidation? Or is it early salvage or second line, as Mark alluded? Prolonged therapy, in my mind, is continuing the original regimen indefinitely until disease progression or toxicity. Full dose, essentially the identical regimen, attenuated dose, usually to mitigate the cumulative toxicity we typically see. Continuation maintenance, you continue some component of the original regimen, usually the non-platinum drug. And switch maintenance is an alternative cytotoxic or targeted agent, what many have called early second line. So this is, I don't know if Mark's still in the room, but this is his trial that looked at a truncated course, 4 cycles of PAC carbo versus indefinite use till disease progression or toxicity with the same regimen. Notice that at progression, patients went on to weekly paclitaxel. As all of you are well aware, this trial showed absolutely no survival advantage. In fact, it showed cumulative toxicity, a doubling in the rate of grade 2 through 4 neurotoxicity in the absence of any major survival advantage. And you heard the answer before. Mark chooses 4 cycles, and whether you use 4 or 5 or 6, I think is probably immaterial, but certainly not more than 6. Another trial from the UK compared 6 versus 3 cycles, so for shortened course versus a more standard course, using somewhat antediluvian chemo, mitovindicin and platinum. And here, too, we see absolutely no advantage, although maybe a tiny trend, whether we look at the entire population, those who sort of met the landmark of 3 cycles, and then the good PS patients. I'd argue that the therapeutic landscape was altered, at least initially, by this trial. This is from Phidias and colleagues, and it's one of the best constructed trials to date. Comparing immediate docetaxel, so switch maintenance, versus more standard delayed docetaxel, second line at the time of progression, in patients who had stabilized or responded to 4 cycles of fairly standard carbo and gemcitabine. Note, about 56% of patients actually made it to the randomization, and in the delayed group, only about 60% actually went on to second line docetaxel. There was tremendous attrition. Positive trial, at least with respect to PFS. We see more than a doubling in the median, and at a year, 20% free of progression compared to 9% in the delayed group, and a trend toward improved survival, about a 2.5-month difference. This trial has been considered negative for survival, but I would argue that it was underpowered, that survival really wasn't the major endpoint here. The trial that clearly changed the paradigm was the Bolani-Cilianu effort. Again, switch maintenance effort, 2-to-1 randomization of PEM versus IV placebo in patients who had stabilized or responded to 4 cycles of chemo du jour, carbo or cis combined with either gem or taxane. PFS, again, was the primary endpoint. Secondary objectives included overall survival, response, disease control rate, and safety. If we look at the baseline characteristics, they're pretty well balanced. Remember, this is before the exclusion for squamous existed, so about a 25 to 30% actually had squamous histology. These were all good performance status patients. About a quarter or so were never smokers. If we look at initial therapy, there was pretty even distribution between PAC carbo and either gem cis or gem carbo. And you note here about 50% of patients actually responded to their initial treatment. So you're culling out a fairly good group. PFS significantly improved, hazard ratio of 0.6. This is for the overall group. It was entirely driven by the non-squamous, I repeat, non-squamous cohort. In the squamous patients, you do just as well with IV placebo. So the hazard ratios respectively of 0.47 and over 1. And if this in turn translated into a survival advantage. So the first study to actually show an improvement in overall survival from 10.5 to 13.4 months, again, confined to the non-squamous cohort, a 5-month advantage. This is solid tumor oncology, folks. You very seldom see that degree of benefit in advanced epithelial malignancies. Squamous, absolutely no advantage. If we look specifically at adeno, the benefits are even more pronounced, from 11.5 to 16.8 months, with a hazard ratio of 0.73 and a highly significant p-value. Relatively mild toxicity, grade 3 and 4 AEs at less than 5% overall. And if we look at overall survival, with the exception of East Asians and squames, pretty much every demographic cohort has a survival benefit. So this is the first randomized double-blind placebo-controlled study to demonstrate a significant overall survival benefit for maintenance treatment in patients with advanced disease. Non-squamous histology was predictive of improved efficacy, specifically with switch Pemetrexed, and administration of PEM in this setting was clearly well tolerated, and at least in the context of the trial, devoid of cumulative toxicity. So it joins many other recent trials that have looked at switch maintenance, and I include Phidias, I include several others, all of which showed a PFS benefit, and 2 of which now have actually shown a survival benefit. And I'll go through the Saturn or Capuzzo trial in a bit more detail shortly, but again, an analogous trial, in this case looking at Erlotinib in that setting. But there are a number of potential criticisms. So I'm going to go through this a bit talmudically, each one of these in turn. A significant percentage of patients will not get to enjoy the fruits of maintenance Pemetrexed. So if we go back to the Phidias trial, remember the JMEN trial took all comers who had stabilized or responded. Well, how many actually do that? Fewer than 60% can even make it to that randomization. The reasons are obvious. It's therapeutic reality. Disease progression, intercurrent comorbidities, patients opting out after 4 to 6 cycles. Many of them would like a vacation in Florida or Hawaii rather than another cycle of chemotherapy. The benefits of PEM, remember, are confined to non-squamous population, probably about 2/3 of the patients we see. So if we do the math, that's fewer than 40% of the entire advanced disease, good PS population can actually make it onto maintenance. Is this early second line, as Mark argued? And can they do just as well if you reserve second-line treatment at progression? So again, if we look at the crossover, the subsequent therapies after treatment, about 80% went on to some additional treatment in the placebo arm, but only 19%, fewer than 20%, actually went on to Pemetrexed. And here's the argument for waiting. This is from the Phidias trial, and look specifically at the control arm, those who got standard second-line docetaxel. And you note here that their median survival, 12.5 months, essentially equivalent to those who got immediate maintenance, that delaying the treatment to standard second-line posed no overt compromise in long-term survival. So why not wait if you are following the patients closely? The toxicity of Pemetrexed, though mild, is not entirely trivial. I showed you this curve, but I didn't show you all grade toxicity. Only 5% dropped out because of cumulative toxicity, but about 20% or so will have asthenia, fatigue, some GI toxicity. I've seen patients who've developed peripheral edema and periorbital edema, and it's not trivial. Particularly the cumulative effects cannot be discounted. Remember, this is the palliative care setting. Many of these patients will stay on maintenance treatment far longer than their original induction regimens. There was no cutoff in time for Pemetrexed maintenance. These patients could go on literally indefinitely. Some have argued that early institution of second-line treatment is unnecessary in a sizable proportion of these patients. So again, if we go back to the JMEN as sort of our object lesson, about half or more of the patients are still free of progression in the control arm and the IV placebo at 2 months, and 10 to 15% are free of progression at 6 months. And we can't downplay the benefits of a therapeutic holiday. Time to recover from platinum-based toxicity. 50% or more will have at least a 2-month window to travel, to participate in family events, to reconstitute their immune system. And many, remember, will remain asymptomatic at the time of progression. That should give us sufficient time to implement appropriate second-line treatment if we need to. Obviously, this approach is unethical if second-line treatment is not available, which unfortunately was the case for many of the patients who participated in that trial. The results of this trial, remember, do not apply to those who receive Pemetrexed, or for that matter, bevacizumab as part of their first-line treatment. The JMEN trial did not include those patients. So if we, again, do the math, 25 to 40% of U.S. patients with newly diagnosed non-squamous, non-small cell get bevacizumab up front, An increasing percentage of chemo-naive patients are getting Pemetrexed, 30 to 50% by my estimate. I suspect in many quarters it's much higher. Neither of these two groups are included in this trial. Very likely more than 50% of potentially eligible patients. So PEM maintenance in this setting arguably is relevant to these two groups, and that robust PFS and overall survival benefit might have been diluted. These concerns have since been addressed by the Paramount and Avapril trials, which I'll go over. Finally, cost. Some have argued that this is the 800-pound gorilla sitting in the corner. In my former institution at Fox Chase, each cycle of PEM is about $5,400. Median of 5 cycles was given in the maintenance arm. Do the math, $27,000 per patient, with a median improvement of 5.3 months per patient. Then the cost per life year gained is about $60,000, at least by my back-of-the-napkin calculation. But I'm actually wrong. Health economists who know far more about this than I have pointed out that you don't use the median. You have to use the mean, and many of these patients go on to 10, 15, 20 or more cycles. And you do that, the cost per life year gain goes up to $120,000, specifically in the non-squamous population. I ask, of course, can we afford to spend this much money in the palliative therapy of end-stage patients? Of course, the CEO of Lilly can change this whole endpoint with a little keystroke on his laptop. So a fungible endpoint, but highly relevant in these tight financial times. Mark alluded to the Saturn trial, the phase 3 of sequential Erlotinib, an unresectable non-small cell. Analogous trial design, a 1-to-1 randomization versus placebo in patients who had stabilized or responded to first-line chemo du jour with platinum. Note that fewer than half actually went on to the randomization. Pretty respectable PFS. The hazard ratio here is 0.71 with lots of zeros in that p-value. And the benefit is seen across the board, including men, Caucasians, squamous cell, and even current or former smokers. If you happen to have an EGFR mutation, you do better yet. That hazard ratio here is astounding at 0.1 with median PFS exceeding a year in that group. Quality of life is improved, particularly when it comes to pain and analgesic use, and we actually see a survival advantage. Hazard ratio 0.81 with a fairly respectable p-value. Only a 1-month advantage of the median, but you can see these curves are separating beyond the median. But again, major criticism. Fewer than half of those enrolled actually made it to maintenance randomization. The toxicity of long-term Erlotinib is not trivial. We've all dealt with these patients with ongoing diarrhea and skin rash, in some case paronychia and fissures. Again, here the grade 3 toxicity is 12% versus 1% overall. But if you do all grades, more than half these patients have some cutaneous toxicity. You'll hear more about how to handle that by Mario Lacouture later. About 20% still have GI toxicities. Survival improvement, the PFS improvement, while statistically significant, may be clinically irrelevant at about a month. And the survival improvement, again, is somewhat clinically underwhelming, at least at the median. And the same criticism that was leveled at JMIN is leveled here. Mandatory crossover to Erlotinib at the time of disease progression was not included in this trial. Only 21% in the placebo group went on to Erlotinib at the time of disease progression. And we look at subgroup analyses. Now, Mark showed you data for the stables on this trial where stable squamous patients seem to have a benefit. But if you look at all comers, even though there's a clear trend, men, Caucasian, squamous, current smokers, the confidence intervals on those hazard ratios all overlap unity. So at least in these post-hoc analyses, it's not necessarily significant. I'm going to finish up in the last 6 minutes with recently reported trials and one that's ongoing. The Atlas trial is analogous to Saturn, but in the setting of bevacizumab. So basically, patients on a Bev-containing regimen are randomized to Bev alone plus placebo versus Bev and Earl. So the same essential study design as Saturn, assuming they've stabilized or responded to their first-line Bev-containing chemo regimen. Virtually identical PFS benefit, hazard ratio 0.72 with a highly significant p-value, about a 16% increase at 3 and 6 months in PFS, but despite a 2-month advantage for overall survival, that difference was not statistically significant. The hazard ratio is just under 0.9, with the usual toxicities, again, rash and diarrhea that we expect to see. So far, I've talked exclusively about switch maintenance. And the question, of course, is there a role for continuation maintenance in non-small cell? One of the first trials, and really probably the most ill-conceived trial to date, was this in gemcitabine plus best supportive care versus best supportive care alone in patients who stabilized or responded to gem-carbo. Not only did this trial fail to show a survival advantage, it actually failed to show a PFS advantage, and I think that was largely driven by the nature of patients on this trial. Median age was generally older, nearly 67, and nearly 2/3 of these patients were PS2. All the positive trials were done in PS0 and PS1 patients. One of the best constructed trials comes from France, randomization to either observation, continuation maintenance with gem, or switch maintenance with Erlotinib, so sort of a hybrid of the Bolani and Saturn approach with mandatory second-line treatment using Pemetrexed at the time of progression. Again, patients who have responded or stabilized with their first-line treatment. GEM, continuation maintenance, actually generating a highly significant benefit. HR here at 0.55 with about a 25% improvement in PFS at 3 months, 2-month advantage and overall median. Erlotinib, not quite as impressive. The hazard ratio is 0.82 with about a 1-month advantage, but still statistically significant. Survival still premature. I don't know if any updates exist yet. I'm certainly awaiting them, but at least at the last iteration, it was not quite statistically significant. Finally, the Paramount trial, which was just updated last year at ASCO for survival, is probably the most important in this regard. And this same trial design as Jamin, 2-to-1 randomization of PEM versus IV placebo in patients who had stabilized or responded to PEM-CIS, so only one upfront regimen. You can see about 57%, just like the Phidias trial, actually made it to the randomization. Here we see a significant improvement in PFS, lots of zeros in that p-value, with a hazard ratio of 0.62. And again, every demographic group seems to have a benefit. And that is, in fact, translated into an overall survival advantage, about a 2.9-month improvement. You see separation, particularly beyond the median. The hazard ratio here is under that magic 0.8 number. And essentially every single group, and note here, no squams were enrolled, every single group seems to have a benefit, including patients who had stabilized on their initial treatment and actually hadn't responded. In fact, the hazard ratio in this group, and some have argued if you're stable, you should go on to switch maintenance. If you responded, you should go on to continuation maintenance. The Paramount results would tend to debunk that. The hazard ratio is actually somewhat better in the stable group at 0.76. So 4 separate phase 3 trials that have looked at continuation maintenance, all but one showing a PFS benefit and one clearly showing a survival benefit with Pemetrexed. I'm going to finish up asking, can we combine platinum and PEM with bevacizumab, and should we continue both PEM and Bev as maintenance? The AVAPEARL trial, I think, gives us valuable insight. This was a European effort with Bev, Cis, and PEM up front, and then a randomization in the absence of progression to either Bev alone, arguably the control arm, versus a combination continuation maintenance of Bev and PEM. About 2/3 of patients actually made it to that point. These are highly favorable patients. By definition, virtually all adenocarcinoma, about a quarter were never smokers. These patients had good PS, and they're somewhat younger with a median age of 60. You see a 3.5-month improvement in PFS from the time of induction, over 10-month time to progression-free survival in the Bev and PEM group. From the time they actually get randomized to either Bev alone or Bev-PEM, that median PFS doubles from 3.7 to 7.4 months. Hazard ratio 0.48. Survival, the HR looks good. It's 0.75, but the p-value is only 0.23. And again, this trial was not designed for survival. It was a PFS endpoint, and I'd argue it was really underpowered to show a major survival difference, although there appears to be a trend. In the US, we don't tend to use cisplatin. We use carbo. So all of you are familiar with the Patel-Hensing data, carbo-PEM-Bev for 6 cycles, followed by Bev and PEM maintenance. This was a phase 2 published just 3 years ago in JCO. Pretty promising results in an unselected, otherwise Bev-eligible population. Response rate over 50%, PFS nearly 8 months, median survival 14 months and counting. And that led to the Point Break trial, which ostensibly was a direct head-to-head comparison and Bev-eligible patients of paclitaxel to Pemetrexed. But note the maintenance arms were different. Bev alone in the control group, the 4599 approach, and Bev and Pem together in the maintenance group. So WAGs have argued with this point, the point break trial would have pointed the way to a new treatment paradigm, and then the nihilists were worried that if it was positive, would this combination break the bank? And I guess the bean counters need not worry. Survival here was totally identical. You can see these two curves are totally superimposable. The p-value is 1.0. However, we do see a benefit for PFS for the PEM-BEV combination. If we do landmark analysis, these are folks who actually made it to maintenance. There's a 2-month difference favoring PFS and actually a 2-month difference favoring survival. But notice there are no p-values or hazard ratios here. And they were asked specifically, where are they? Well, it wasn't part of the original study plan, so we didn't do it. Stay tuned. Obviously, we're going to insist on that. The trend is still there, but I suspect it was not significant. Otherwise, we would have heard about it. So the one ongoing trial, and there are others, but the biggest trial that will probably settle this whole issue is ECOG 5508 that's comparing a standard continuation BEV alone versus switch maintenance with PEM versus a hybrid of both PEM and BEV together. This trial is about 2/3 accrued. So I'll end with these conclusions. Maintenance treatment is a reasonable option in fit, motivated patients who have stabilized or responded to initial platinum-based treatment. BEV maintenance is part of ECOG 4599 paradigm, but it's never been proven versus observation in randomized phase 3. There are no phase 3 trials that have shown it. PEM is well tolerated and certainly convenient, and we've seen both a PFS and overall survival benefit in both the continuation and switch settings. That benefit is confined to non-squamous histology. The striking survival advantage seen with PEM in this setting would have been far more credible had it been observed in the context of mandatory crossover, which was not featured, and cost may ultimately be the 800-pound gorilla. Maintenance treatment with Erlotinib, as we've pointed out, after cytotoxic chemo, does demonstrate a PFS and overall survival benefit. For whatever reason, most of us don't seem to be using it. The survival benefits are a bit more robust in the phenotypically favored subgroups, so Asians, women, adenocarcinomas, never smokers, not secure, intriguingly, in the mutation-positive cohort because of crossover. The not-so-striking survival benefit, again, would have been far more credible had there been mandatory crossover in the control group. I think all of these studies should have quality of life. And to date, we have no survival advantage for combination Bev-PEM or Bev-ERL versus Bev alone in the maintenance setting. So I'll end here.